Well, thank you for that kind introduction. So it's my pleasure to be here, and I really like these small-scale meetings because I think usually there is ample time for discussion. And as already mentioned by Maria, Angela, and Catherine, I really encourage you also to ask questions and to be actively involved. So today I would like to talk about adipose tissue dysfunction in obesity and how an impaired functioning of adipose tissue might contribute to insulin resistance and type 2 diabetes. At first I would like to briefly touch upon the pathophysiology of type 2 diabetes and actually make clear that insulin resistance is really one of the key steps in the etiology of this disease. And thereafter I would like to touch upon the relationship between body composition and metabolic health, and move on then into a relatively new concept, the concept of metabolically healthy obesity. And actually I would like to convince you that this is a misleading concept, at least in my opinion. Nevertheless, I think we can use this concept to better understand why some obese subjects do develop complications and others do not. And the last part of my presentation will be about adipose tissue dysfunction in obesity-related insulin resistance. And I will discuss also some of our own data on a relatively novel factor that might be implicated in adipose tissue dysfunction, namely the oxygenation of adipose tissue. So, for this audience, that's I think quite clear that the prevalence of obesity has actually reached epidemic proportions. So nowadays, more than 50% of the population is overweight, and about 12% is clinically obese. And this poses really a major public health issue because obesity is one of the major risk factors for the development of several chronic diseases, including cardiovascular disease, type 2 diabetes, non-alcoholic fatty liver disease, and also certain types of cancer. And because obesity is one of the major risk factors for diabetes, it's not surprising when we look at prevalence data that hand in hand, I would say, with the increasing prevalence of obesity, we also see a steep rise in the prevalence of type 2 diabetes. So these are data from the US, and we can also see data in 2010 that in about 1/3 of the states of the US, the diabetes prevalence has reached around 10%. I think that is huge. So how does type 2 diabetes develop? So insulin usually suppresses glucose production by the liver, and it also stimulates glucose uptake in peripheral tissues, mainly skeletal muscle, which is responsible for about 80% of insulin-stimulated glucose uptake. So when, for certain reasons, insulin resistance develops, the efficacy of insulin to reduce hepatic glucose production and to stimulate glucose uptake is impaired. And you might anticipate that this would lead to an increase in blood glucose concentration. However, that is actually not yet the case. So you can see the blood glucose concentrations depicted by the red line, insulin resistance by the blue line. But why can we see that the blood glucose concentration stays normal? That is because, fortunately, we can compensate for the insulin resistance by just producing more insulin. So the pancreas just compensates for the insulin resistance that is taking place. Nevertheless, if there is a worsening of insulin resistance, and if the pancreas is not producing sufficient amounts of insulin, then we can see that there is already a slight increase in glucose concentrations apparent in the circulation. And that is what we call, what sometimes is referred to as the pre-diabetic state, or at least the state of impaired glucose metabolism. And it is not until there is really a progressive decline in beta cell function that type 2 diabetes develops. So you can then see that there is a steep rise in blood glucose concentration. So when looking at this slide, I always say that this gray area over here is really a window of opportunity. So if we better understand how insulin resistance develops, and if we can prevent or reverse insulin resistance, we may be able to prevent or at least delay the onset of type 2 diabetes. Right? So at the population level, we know that body composition is related to metabolic health. And BMI at the population level is a good predictor of metabolic health, but not at an individual level. And this is, of course, an extreme example, but if we compare two people with a similar BMI, one can be an abdominally obese person and the other one can, for example, be a bodybuilder. And the person on the left is metabolically unhealthy, whereas the person on the right is relatively metabolically healthy, I would say. And that is the reason, of course, that we know that body fat percentage is important. So total fat mass plays an important role in metabolism and in metabolic health. However, even total fat mass does not predict your metabolic health at an individual level. And I'll show you some examples and come back to that later on during my talk. So the first two are quite logic if I'm saying that adipose tissue mass plays a role in metabolic health. So if you gain weight, usually insulin sensitivity goes down. And the opposite, if you lose weight, for example, via a dietary intervention, insulin sensitivity usually, not always, but it usually increases. However, and I'll come back to that in a minute, when you look at obese subjects that are relatively metabolically healthy, they can have a normal insulin sensitivity, despite the fact that they have quite a lot of adipose tissue mass. And it becomes even more, well, not conflicting, but if you look at patients that undergo liposuction, so the surgical removal of subcutaneous adipose tissue, sometimes about 8 kilograms of subcutaneous adipose tissue is removed. So what's happening with insulin sensitivity? Does it improve? No, nothing happens. There are also elegant studies performed by Sam Klein in the US. We have another situation. Patients that are treated with TZDs, so thiazolidinediones, that are insulin sensitizers. So, by definition, you will see an increase in insulin sensitivity in these patients, despite a significant gain in body weight during the first year of treatment. So that can be also 4 to 5 kilograms of fat mass gain, but insulin sensitivity increases. And lastly, patients with lipodystrophy, for example. So that are patients that partially or completely lack adipose tissue. So a low amount of adipose tissue, but these patients are severely insulin resistant, and most of them will develop type 2 diabetes. So as I said, I come back to these conditions later on in this talk, and I hope you can then explain or understand why this is the case. But we know that in addition to total body fat mass, body fat distribution also plays a very important role in insulin sensitivity and metabolic health in general. So we know that abdominally obese persons are at increased cardiovascular disease risk and at increased risk of developing diabetes, whereas, in fact, and that's quite striking, if you store more fat at the lower body part, you're even protected against cardiovascular disease and diabetes. So that is what we know, the apple and the pear shape form of obesity. But then look at this example. You can have two subjects matched for BMI, body fat percentage, and body fat distribution with a similar waist circumference. So two persons both abdominally obese. But one can be metabolically unhealthy and the other one can be relatively metabolically healthy. So that is the concept of metabolically healthy obesity. And why is that? How is that possible? Well, let me first define metabolically healthy obesity. And in literature, you will not find a consistent definition. So this is a relatively new concept, but a definition that is relatively commonly used in literature is the absence of type 2 diabetes, hypertension, and dyslipidemia. So when using this definition, we know that about 10 to 25% of the obese individuals are metabolically healthy. And an interesting observation is that within this group of metabolically healthy obese, there is a very low prevalence of insulin resistance. So about 15% of these obese individuals are insulin resistant. And this is an interesting study published by the group of Matthias Blür in Germany several years ago. And what they did, they measured insulin sensitivity in quite a large group of subjects, metabolically healthy obese individuals, but also lean control subjects. So maybe not all of you are familiar with the gold standard measure of insulin sensitivity. That is the hyperinsulinemic euglycemic clamp. So basically what you do is you infuse insulin. If you wouldn't do anything else, glucose would go down because insulin suppresses glucose production by the liver, as I mentioned, and it stimulates glucose uptake. And you want to maintain euglycemia during this test. So you co-infuse glucose. And if you're very insulin sensitive, you need to co-infuse more glucose, right? So the amount of glucose you need to infuse is a measure of insulin sensitivity. The higher the insulin sensitivity, the more glucose you need to infuse, right? So in the total population, you can see here this dotted line, that is the fitted line that indicates basically that the higher the BMI, the lower the insulin sensitivity, as expected and as we know. But now look at Morbidly obese subjects with a certain BMI, let's say BMI of 45, you can see that there is a huge inter-individual variation in insulin sensitivity in subjects with exactly the same BMI. So there are some individuals that are severely insulin resistant, and there are also some obese, metabolically healthy individuals that have the same insulin sensitivity as a non-obese reference population. So completely normal insulin sensitivity. But an important question is, are all these metabolically healthy obese individuals really healthy, as the concept suggests? What they did in the same study is they divided that group of metabolically healthy obese individuals into a group that is relatively insulin sensitive and in a group that is insulin resistant. And what you can then see, if you look at just plasma metabolites, that in the more insulin-resistant obese individuals, there was already a significant higher plasma glucose concentration, higher triglycerides, and lower HDL cholesterol. In other words, are these metabolically healthy obese individuals really healthy? I don't think so. And you can actually say that these insulin-resistant metabolically healthy individuals are on their way to becoming unhealthy obese. And that is also supported by a recent meta-analysis that has been published in Obesity Reviews 2 years ago. And what they did is they prospectively followed, in several studies, metabolically obese individuals. And they just monitored incident cases of type 2 diabetes. And the conclusion of this meta-analysis was that metabolically healthy obese individuals have a 4-fold increased risk of developing type 2 diabetes as compared to healthy normal weight individuals. So bottom line is that although you can say, well, based on their definition, they're metabolically healthy, they do have a 4-fold increased risk of developing diabetes. So that's the reason why I'm saying I think it's, in general, for the general public, and if you want to use it in the media, I think it's a misleading concept. It suggests that obesity is not a problem, whereas we all know it actually is a huge problem. So let's come back to the comparison I made. 2 individuals, similar BMI, similar total amount of body fat, and also similar body fat distribution, but differences in metabolic health. I think that clearly indicates that it's not only the mass, and it's not only the distribution, it's also really the adipose tissue function that is very important in determining metabolic health. And we now know that when you look at the adipose tissue and the phenotype of the adipose tissue, that the size of the fat cells is an important determinant of insulin sensitivity. So we all know that in obese individuals, the fat cells are bigger as compared to lean, healthy individuals. But an interesting observation is that abdominal subcutaneous adipocyte size, so adipocyte hypertrophy, is an independent marker of insulin resistance, and it can even predict type 2 diabetes. So there are 2 very nice prospective follow-up studies performed in Sweden showing that if you assess adipocyte at a certain moment in time, that you can predict who will develop diabetes and who will not, in simplistic terms. And why is that? Well, during a long-term positive energy balance leading to weight gain, adipocyte size will actually increase in most individuals. And this is accompanied by impairments in lipid metabolism, by alterations in the secretion of adipokines with a shift towards a more pro-inflammatory phenotype. We'll see that several immune cells will infiltrate the adipose tissue, so not only macrophages, but also mast cells, dendritic cells, T cells, different kind of immune cells, together worsening the inflammatory phenotype. And these impairments in lipid metabolism and these infiltration of immune cells also induces local insulin resistance. But this has not only local effects, it also affects whole body insulin sensitivity and metabolic health. And the reason is that these hypertrophic adipocytes are already overloaded with stored triacylglycerol, so the lipid buffering capacity is impaired. And we know that in subjects with large fat cells, the storage of dietary fat is impaired. So if you ingest a mixed meal or a high-fat mixed meal, more of these fatty acids will be stored in other tissues than adipose tissue, because these fat cells are just already overloaded with stored triacylglycerol. In other words, hypertrophic adipose tissue is characterized and will lead to lipid spillover in the circulation. So these lipids will be directed towards other tissues, such as the liver, but also skeletal muscle, the heart, the pancreas, all other tissues you can think of. And we know that lipid accumulation in liver and also in skeletal muscle is closely related to insulin resistance. And inflammation in adipose tissue might also contribute to systemic low-grade inflammation. Although I would like to stress that the evidence for this in humans is limited. It's often mentioned in a lot of literature, right, that low-grade inflammation is present in obese individuals. I have serious doubts about that if you do a good search through literature. Animal data are clear-cut. In humans, I think this is still under investigation. So coming back to this slide again, adipose tissue function is important. Well, if I state it like that, do you see differences in adipose tissue function between the metabolically healthy and unhealthy individuals? I think that's a logical question to ask. And yes, there are differences. So this is again data from the group of Matthias Bleur. And they first of all could demonstrate that adipocyte size is significantly increased in metabolically unhealthy as compared to metabolically healthy individuals. Important to mention here, these subjects are matched for BMI, age, and gender. And if we look in a little bit more detail to what is happening in adipose tissue, they also demonstrated that the number of macrophages that are present in the adipose tissue is significantly increased in the obese, more insulin-resistant individuals as compared to the insulin-sensitive obese individuals. And this is both in the visceral adipose tissue depot as well as in the subcutaneous adipose tissue depot. And they also provided data based on gene expression, in this case of CD68, which is a macrophage infiltration marker, and they see the same pattern. So more macrophages present in the adipose tissue of the metabolically unhealthy obese. And when you look at the panel on the right-hand side over here, they also measured whether this translates into functional differences. So are these fat cells of metabolically unhealthy obese individuals more insulin resistant? And the answer is yes. So they measured glucose uptake in adipocytes under basal conditions and during insulin stimulation. And you can see that the insulin-stimulated glucose uptake is much higher in the insulin-sensitive as compared to the insulin-resistant metabolically healthy obese. So to sum up, the metabolically healthy obese show less macrophage infiltration in the adipose tissue, smaller adipocytes, and these adipocytes are also more insulin-sensitive. So I promised I would come back to this slide, and I hope I've at least partly convinced you that fat cell size is an important determinant of metabolic health and insulin sensitivity. So when you have a reduction in fat cell size, it leads to less storage of fat in non-adipose tissue, so less ectopic fat storage. And it might also contribute to a reduction in inflammatory cytokines, together contributing to improved insulin sensitivity. So now look at these conditions separately. What is happening with adipocyte size? When we gain weight, fat cell size increases, insulin sensitivity goes down. When we lose weight, we see the opposite. In the healthy obese, as I just explained, fat cell size is relatively normal, at least it's lower than in the metabolically unhealthy individuals. And we also see a normal insulin sensitivity in a large group of these metabolically healthy obese. Subjects undergoing liposuction, what's happening with fat cell size? Nothing. The remaining fat cells keep the same size. You just remove a lot of tissue. You can even question what will happen if you would follow up prospectively subjects that have undergone liposuction. Because if you remain your dietary, if you don't change your lifestyle, have the same energy intake, same energy expenditure, where is the fat going? It needs to be stored in the remaining fat cells. So you can speculate that these adipocytes will actually store more triacylglycerol, and in the long term it might even lead to a more rapid development of insulin resistance. That's at least what I would anticipate. Treatment with thiazolidine diones, the insulin sensitizers, well, this is actually a PPAR gamma agonist, and it stimulates fat cell differentiation. So treatment with TZDs leads to more smaller fat cells, so more healthier fat cells. This is accompanied by an improvement in insulin sensitivity. And lastly, the patients with lipodystrophy, as I mentioned, they just lack the adipose tissue to store the dietary fat. So where is the fat going? Exactly to the non-adipose tissue, liver, muscle, heart, etc. And therefore these subjects are severely insulin resistant. So in a way, I think these data actually suggest that indeed the phenotype of adipose tissue and the size of the fat cells play a very important role in determining insulin sensitivity. But the key question really is what triggers adipose tissue dysfunction? Because I mentioned at the beginning, if we know why adipose tissue dysfunction occurs, we can intervene, right? We can develop interventions. And for time reasons, I won't discuss all classical risk factors or inflammation in adipose tissue and those things. I briefly touched upon that. But I would like to spend a few slides on a novel factor, and that is the oxygenation of adipose tissue. And it was actually Paul Trayon from the UK who postulated several years ago that during the progressive development of obesity, angiogenesis, so the formation of new blood vessels, might be insufficient to maintain normoxia in the entire adipose tissue depot. And as a consequence, a relative oxygen deficit, or often used in literature, hypoxia, might occur. So is there really evidence for adipose tissue hypoxia? In rodents, yes, there is. So this is a study from Jing-Pang Ye, published about 9 years ago. And they first of all demonstrated that the oxygen tension, PO2, in different adipose tissue depots was significantly lower in OB mice as compared to lean control mice. And they confirmed this by looking at gene expression of hypoxia-responsive genes, for example, HIF1 alpha and GLUT1. So gene expression of these two genes was significantly higher in the obese animals. And they also used pimonidazole hydrochloride, which is actually an agent that forms adducts against thiol groups that are formed under hypoxia. To put it simply, if there are hypoxic areas, it will be stained by this agent, pimonidazole. And indeed, both by Western blotting and also by immunostaining, these authors could demonstrate that there are more hypoxic areas in the adipose tissue of the obese as compared to the lean animals. And around 3 other animal studies to date have indeed demonstrated that there is adipose tissue hypoxia in obesity, so in animal models. But what about humans? So at the same time, actually, we were already developing a novel method to measure adipose tissue oxygen tension in humans, which is not easy to do. And we developed an optochemical measurement system, which is based on a technique called microdialysis. So briefly, we introduce a microdialysis catheter, which is a 2 centimeter long catheter with a semi-permeable membrane at the end of the catheter. So the oxygen that is present in the adipose tissue can easily diffuse into this catheter, and that is then directed via an airtight steel tubing towards a device which we call flow-through cell. And this flow-through cell contains a very accurate oxygen sensor. So we can now continuously monitor oxygen tension throughout the day in human adipose tissue. And currently we're also doing that, by the way, in skeletal muscle. So we set out and compared, first of all, adipose tissue oxygen tension in obese insulin-resistant as compared to lean insulin-sensitive individuals. And we knew from previous studies from our group and others that adipose tissue blood flow is reduced in obesity. In other words, oxygen supply is lower. So we expected basically to see that based on the lower blood flow, oxygen tension would be lower. Surprise, surprise, it was not the case. We found significantly higher oxygen tension in obese as compared to lean individuals. And I won't show you all the data, it's published, but we have now some evidence, and also from other papers, that this might be due to a lower metabolic rate of the adipose tissue. So it's the balance between oxygen supply and oxygen consumption, and we think that the oxygen consumption side of that balance is more important. And also important to mention here is that the physiological range of oxygen tension lies around, or ranges between 3 and 11%. And I think that's very important to bear in mind when you look at all the cell culture studies that have been done so far, that usually uses 1%, which is extremely low oxygen tension. You can imagine that you induce a stress response when you lower the oxygen tension here to a few percent, right? That is not surprising that you would then see inflammation. I think important to bear in mind for future studies. And an interesting observation was that we found a significant positive association between adipose tissue oxygen tension and several markers of chemoattraction, macrophage infiltration, and inflammation. In this case, for example, TNF-alpha. So the higher the oxygen tension in obese individuals, the higher the inflammation. And even more striking is the finding that we saw an inverse association between adipose tissue oxygen tension and insulin sensitivity at the whole body level. In other words, subjects with a higher oxygen tension, and that are the obese individuals, have a lower insulin sensitivity. So we wanted to follow up on this because this is just cross-sectional data. So we recently completed a diet-induced weight loss study in humans. So 15 overweight and obese, but otherwise healthy individuals received a very low-calorie diet for 5 weeks to achieve at least 8% weight loss. And this was followed by a 4-week weight maintenance diet. And as expected, body weight was decreased by around 10%. We saw a reduction in body fat percentage of around 6%. And also, as expected, we saw a reduction in fat cell size. So, together, known from literature, contributing to an improvement in insulin sensitivity after weight loss. But what was happening with oxygen tension? And interestingly, we found that, and that's in line with the data I just showed you, that there was a very marked and consistent reduction in adipose tissue oxygen tension following weight loss. So 14 out of the 15 individuals that we studied showed the reduction. And on the right-hand side, you can see the mean values. So there was a reduction in oxygen tension of about 20%. And that was accompanied by improved insulin sensitivity. So these data, as I said, are in line with the previous data showing higher oxygen tension in obesity. So if you lose weight and go more to a lean phenotype, we indeed see the reduction in oxygen tension. And currently we're also doing mechanistic cell culture experiments to see if indeed oxygen tension is causally involved in the metabolic impairments that we see at the level of adipose tissue. But based on these data, we wanted to answer the following question. Does chronic hypoxia exposure affect adipose tissue inflammation and metabolism? So is it indeed the case that if you would lower oxygen tension in adipose tissue, that you can improve the adipose tissue phenotype? So we first set out and performed an animal study. So black 6 mice were exposed to hypoxia for 21 days. And I won't show you all data for time reasons, but the main interesting findings, I think, were that hypoxia exposure significantly reduced gene expression of several macrophage infiltration markers, both in visceral and subcutaneous adipose tissue. And we also performed stainings for macrophages and quantified the number of macrophages present in the tissue. And in line with gene expression data, we found that hypoxia exposure reduced the number of macrophages present in the adipose tissue, both in visceral and subcutaneous adipose tissue. We also measured the expression of several other genes in the adipose tissue, so inflammatory genes. And the general message here is that hypoxia exposure lowered the gene expression of several pro-inflammatory markers. So reduction in TNF-alpha, reduction in IL-10, reduction in leptin. And you can see that in the visceral adipose tissue, at least, there was a significant increase in the expression of the insulin sensitizing factor adiponectin. And when we look at metabolic markers, we also had some interesting findings, in my opinion. Hypoxia exposure increased gene expression of PGC1 alpha, PGC1 beta, TFAM, which is involved in mitochondrial biogenesis, and also a huge increase in gene expression of UCP1. And we did not look formally at browning of adipose tissue, when we had paraffin-embedded tissue, and just by eye you could see that the tissue looked indeed more brownish. So we did not mention that explicitly in the paper because we don't have robust data for that, but it might even suggest that lower oxygen tension might contribute to browning of adipose tissue, at least in these animals. And this concept was recently applied in humans by the group of Eric Ravison from the US, and they exposed obese humans to moderate hypoxia for 10 subsequent nights. So during sleep, subjects were exposed to 15% oxygen tension in the environmental air. And again, they measured insulin sensitivity by the clamp, so the glucose disposal rate. That's similar to what I already mentioned, the glucose infusion rate during such a clamp. The higher your insulin sensitivity. And they could demonstrate that hypoxia exposure significantly increased whole body insulin sensitivity. They also collected skeletal muscle biopsies to do some cell culture work, and they exposed myotubes to hypoxia. And there they found that hypoxia exposure significantly increased basal but not insulin-stimulated glucose uptake. And an interesting finding, and they did not really comment upon that in their paper, was that adipose tissue oxygen tension tended to be reduced after this intervention. So it's tempting to postulate that the reduction in adipose tissue oxygen tension might at least partly have contributed to the improvement in whole body insulin sensitivity in this study. And that is also what we postulated 2 years ago in Diabetes Care. So this brings me to my main conclusions. First of all, I think we can say that BMI and body fat mass, as well as body fat distribution, are very important determinants of metabolic health at the population level. Nevertheless, I think that adipose tissue dysfunction, which may partly be explained by changes in oxygen tension in the adipose tissue, contributes to insulin resistance and the risk of developing chronic diseases, and may in fact better predict disease risk at the individual level. Metabolically healthy obese individuals are relatively protected against chronic diseases as compared to their metabolically unhealthy counterparts because of a better adipose tissue function and, as a consequence, less fat storage in non-adipose tissues. And finally, to date, I think both observational and intervention studies have demonstrated that physiologically low adipose tissue oxygen tension is accompanied by improved adipose tissue function and may also contribute to the improvement in insulin sensitivity in humans. So finally, I would like also to thank the colleagues in the lab in Maastricht in the Netherlands, and also, of course, the financial support by the EASO and also the Dutch Diabetes Research Foundation. Thank you for your attention.
Thank you. Very interesting. I'm not really familiar in this whole field, so I was just wondering, you say that in the beginning you say that the metabolically healthy individuals might not be really healthy because it depends on, well, or they might be going towards unhealthy. Do you know anything, can you tell us anything about how long you have to be kind of exposed to these unhealthy influences before you really go to this unhealthy state? Is there anything known about this?
That's a tricky question. I think you can only address that question correctly if you do prospective studies and if you follow subjects in time to see when changes are occurring. And I think that is really a value of large cohort studies that we certainly need to address that question formally. You cannot answer that, in my opinion, in cross-sectional studies. What I think is also an important factor that might underlie these differences is the possibility to stimulate adipocyte differentiation. So as I mentioned, the metabolically relatively healthy have smaller fat cells. So as long as you can stimulate and have beneficial effects on adipocyte differentiation, you can better store the lipids, dietary lipids. You can keep the adipose tissue inflammatory phenotype in a more healthier condition, thereby preventing the development of insulin resistance. But I think we don't know the answer to your question right now. No.
Thank you. Oh, yes.
I'm scared of using these. Is there any, so if I'm getting it right, you're saying that the cell size is the important factor. Mm-hmm. And you mentioned there about differentiation, and so are you suggesting that the people who maintain that metabolically healthy obese state have a greater cell number? Is that correct? And I was just also wondering whether, in addition to that, whether there's any evidence around fat utilization beyond storage, and whether actually that fat isn't getting to a state of storage because it's being either utilized elsewhere or burnt or used differently.
Yeah, thank you for that question. Very good points. So indeed, there is some evidence that total adipocyte number is higher in the metabolically healthy obese, right? If they have the same adipose tissue mass and smaller fat cells, the number should be higher. There is some evidence also for that. And I think you also raised a very important point, and I did not touch upon that today. That is, of course, in general, the aerobic capacity and the capacity to oxidize fatty acids. So we know that that's also the concept of the fat-fit individual, right? That it's that obese individuals that are quite active and don't show too much sedentary behavior are actually, when you look at plasma metabolites, more healthier than lean counterparts that are very inactive and so on. So I think indeed substrate utilization and oxidative capacity, and then we're focusing on muscle but also on liver, is a very important factor in that as well. And we don't have a lot of studies published yet that have really phenotyped the subjects based on substrate utilization, also after different challenge tests so far. But I think there will be very interesting studies to perform.
Yeah, just that idea of even not necessarily even just the fat fit, but whether people matched for a given fitness may just be naturally burning more fat at rest and during exercise or whatever, meaning that actually fat's being used elsewhere post-prandially as opposed to being stored.
Yeah, that's a little bit the chicken and the egg story, because we know that insulin sensitivity is also related to substrate utilization. So that is not an easy question to answer, I think. But in the coming years, I'm sure we will get more data related to that. Yeah.
There is maybe time for one short question.
So then, rather than a question, I have a comment, which is, let's say, propedeutic to my presentation in the next session, related to the metabolically healthy obese subject, and going back to her question just a few minutes ago. I believe that you mentioned, actually, that one of the problems when we discuss about the metabolically healthy obesity is related on how we classify this individual as metabolically healthy or not. The criteria, whether we use the metabolic syndrome criteria, whether we use simple index such as plasma glucose, HDL, or triglyceride, as you mentioned in your slide, or whether we use more direct assessment of insulin sensitivity using clamp studies, very few studies, obviously, because of the complexity of the techniques, or whether we use a surrogate marker of insulin resistance. So some of the data may be confusing and misleading because the population are classified with different criteria, and that means that we are looking at different people, looking at those different papers. The other issue, in my view, is related when we discuss about the potential relevance in terms of prognosis of these individuals is the length of the observation period. And when we discuss about the survival of this individual, of the risk to have a cardiovascular disease or the risk to develop type 2 diabetes, as in your meta-analysis, the meta-analysis you mentioned, the critical point, in my opinion, is the duration of the observation, especially when we discuss about survival and cardiovascular disease. We do know that when we discuss about insulin resistance, we need to wait at least 10 to 15 years in order to pick up a difference in terms of prognosis of these individuals. And this is, in my feeling, another reason why the data related to metabolically healthy obesity are discordant. Probably picking up the very long observational period, we might be able to pick up the beneficial effect of metabolically healthy environment rather than with shorter studies. Yeah. And the final comment, and then I agree with you. Mm-hmm. There is no answer because we have no cohort in order to understand whether this metabolically healthy status will last forever or whether at a certain point will go down. Actually, an increased availability of substrates, metabolically speaking, it is well known if it's glucose, fatty acids, or amino acids, will determine within few hours the development of insulin resistance when administered intravenously in normal healthy subjects. So this is something going on acutely. During the normal health, let's say everyday lifestyle, it's very difficult to understand whether the excessive calories in our diet at a certain point will trigger some metabolic abnormalities which is not going to be reverted and will change the status of your individual from metabolically healthy to metabolically unhealthy. We do need these sort of studies, I agree.
Yeah, and for time reasons, just in 2 sentences to comment on your comment. To a large extent, I completely agree with you, and we need those large follow-up studies. But I would like to emphasize that in the study, the very elegant study, I think, by Matthias Bleuer, these subjects were indeed divided into the metabolically healthy and unhealthy based on clamp-measured insulin sensitivity. So I think, and that was quite a large population. But I do agree that other papers in the field of metabolically healthy or unhealthy obesity, small-scale studies, you should take care in interpretation of the data there. Yeah, absolutely.
Thank you.